Good evening, everyone. I warmly welcome you to our CellTalk webinar. In today's session, Mr. Numair Arshad will be presenting research titled Efficacy and Safety of GV1001 in patients with moderate to severe Alzheimer's disease already receiving donepezil, a phase 2 randomized double-blind placebo-controlled multi-center clinical trial. Numair is a clinical content writer at Renix. He is responsible for writing scientific medical white papers and blogs. His work is centered around making complex scientific concepts accessible to lay people. He is currently pursuing PharmD at Lahore University. His writing at Renix focuses on precision medicine for cancer patients. Numair is currently working on GeneMap projects and delivering scientific content that aims to provide gene-centric information for various diseases and their treatments. Renix has allowed him to gain leadership in various projects related to content. So now I welcome Numair to take the floor.
Thank you, Aditi, so much for the kind introduction. My presentation is based on the paper that is titled Efficacy and Safety of GV1001 in patients with moderate to severe Alzheimer's disease already receiving donepezil, a phase 2 randomized double-blind placebo-controlled multi-center clinical trial. So it's the results of a phase 2 clinical trial, and the paper is originally authored by Go and others. The journal in which the article was published is titled Alzheimer's Research and Therapy. Its impact factor is 6.1, and the year in which this article was published in this journal is 2021. So let's start with the introduction of Alzheimer's disease first. Alzheimer's disease, as we all know, it's a neurogenerative disease, and during this disease, the neurons continue to die progressively, and that impairs short-term memory and affects the judgment. The patients have poor judgment and abnormal behavior, and all of these symptoms, they severely reduce the quality of life of the patients. And in 2022, over 55 million people are living with dementia, and as we all know that Alzheimer's disease is the #1 cause of dementia, so that makes Alzheimer's disease a healthcare challenge of the 21st century. Now some general background into this research. AD, as we already know, it's a progressive disorder. If we look into the major aspects of its pathophysiology, these are beta-amyloid deposition and the neurofibrillary tangles of hyperphosphorylated tau protein. But these are not the only two factors. There are other factors, whether or not they are primary or secondary, that's another debate, but there are definitely other factors. One of them is inflammation. Recently, there has been a lot of work going on the link between the gut microbiome and AD, so that's another factor. But in this one, I will be focusing on the inflammation only. The present challenges are that all of the drugs that we are currently using for Alzheimer's disease, they do not stop the neurodegeneration, and they are currently only manage symptoms. They are mostly cholinesterase inhibitors. What they do is these drugs inhibit a natural enzyme in the brain, which naturally breaks down the neurotransmitter acetylcholinesterase. So by doing that, these drugs, they increase the level of this neurotransmitter, and thus they have some positive effect on the memory and some other symptoms of Alzheimer's disease. But they by no means they stop or even control the neurodegeneration, which is the main factor in Alzheimer's disease. So in the recognition of this, there has been a lot of effort in the development of new drugs that are, but that drugs are mostly targeting the amyloid plaques only. So I just want to present this paper because it's based on some other factors as well. So as we discussed, the pathophysiology it's multifaceted, and not just the amyloid plaques they should be targeted. Some other aspects should be targeted, and in this one, the inflammation is the focus. The inflammation, if it can be targeted, I think it can improve the overall standard of living of the patients, and that's what the authors proved in this clinical trial. So the objective of this clinical trial is to provide alternate ways of targeting the pathophysiology of Alzheimer's disease. And for that, they recognized an antioxidant drug, that is GV1001. It's actually, the drug was actually established for cancer, but it didn't work there. So it is being used here for Alzheimer's disease as an antioxidant. Now moving on to methodology. The sample size, it was determined to be 78. Actually, the authors, they couldn't find an exact replica of this trial, so they had to make some guess around what will be the appropriate sample size for this phase 2 clinical trial, and the number that they eventually agreed on is 78. And considering the 20% dropout, they recruited 96 patients. And if 20% of them drop out by the end of the study, then we're left with 78. And all of the patients, or all of the participants, they were aged between 55 to 85. That's the age group within which the Alzheimer's disease is most prevalent. And they had to meet the some criteria. And that criteria is they had to be diagnosed with probable AD. And it was defined by certain standards. First one is National Institute of Neurological and Communicative Disorders, and then stroke, Alzheimer's disease and related disorders association criteria, and then another one, Diagnostic and Statistical Manual of Mental Disorders. So if you can see here, it is the fourth edition only, but why they didn't do the fifth edition, I think it can be mentioned as a limitation, because the latest one is the fifth edition of DSM. And then another point in this criteria is the Korean mini mental state examination score had to be equal to 19 or less than 19. Then another one is the global deterioration scale. Score should be between 5 and 6. Why they didn't go beyond number 6 is if a person has GTS score of 7, it means that they won't be able to participate properly in the study. They won't be able to cooperate as much as the primary endpoint wanted them to. So for that reason, they only restricted to GTS score number 6. And then another very important one is that they all of the participants, they were receiving donepezil for longer than 3 months. As I discussed earlier, this is not this investigational drug is not trying to be the standalone treatment for Alzheimer's disease. It is only providing like another way to target the multifaceted pathophysiology of Alzheimer's disease. And for that reason, it is trying to be a combinational drug, so that using different drugs, the overall pathophysiology can be managed better. And even if that doesn't altogether cure the Alzheimer's disease, if it results in better quality of life, that would be a big improvement just considering the current scenario. And then after the initial screening and evaluation, they just performed MRI and CT just to exclude any participant that was having some of psychiatric problems or other forms of dementia that could have interrupted the evaluation. Then moving on to randomization. For the randomization, they created 3 groups. The group number 1, it was the placebo group. It was given the normal saline. And then the group 2, it was given the investigational drug, that is GV1001, and its dose was 0.56 milligram. And then group 3, it was also given the investigational drug, but its dose was double as compared to group number 2. And they divided all the participants equally between these three groups, and they use the interactive web response system for that purpose. And since it is a double blind clinical trial, it is a standard to have double blind clinical trials. So all of the investigators, the participants, and the caregivers, all of them, they were blinded to the treatment assigned. And for that purpose, they had to make the placebo visually identical to the actual drug. So it was an injection, subcutaneous injection. So the normal cell line, it was visually identical to the actual drug, so that the care providers, they didn't know that if they are giving the actual drug or the placebo to the participants. So that makes it double blind clinical trial. And then the trial lasted for 24 weeks, and during the first 4 weeks, the participants were given one injection every 1 week, and for the last 20 weeks, they were given one injection every 2 weeks. So if you count the injection, it comes out to 14 injections in total. Then is the assessment of outcome. The evaluation, they were performed. One is the baseline. It's standard to perform evaluation on the baseline, just to have in record what their basement standards and of they were performing before coming into the clinical trial. Then one assessment was performed mid trial, that is week number 24, and then one was performed at week 24. That is the end of this clinical trial. And for the primary efficacy endpoint, they established that it could be severe impairment battery score at week 24. And then for the secondary endpoint, they included a bunch of other standards, that is clinical interview based impression of change. Here you can see why they didn't go beyond number 6 in the GDS score, because if they had gone before number 6, beyond number 6, it would have been very difficult to perform these all tests on the participants. So in addition to that, the some other secondary endpoints are clinician interview based impression of change plus caregiver input, clinical dementia rating, sum of box, Alzheimer's disease, cooperative study activities of daily living, and then a neuropsychiatric inventory, again the MMSC and GDS score. These were in the criteria as well, but they also included in the secondary outcome. And since it's a phase 2 clinical trial, it means that the drug is already proven to be safe in human beings, but still they included the safety endpoints. And during that, they took into consideration the lab test results, the vital signs, observation related to safety, that can be the electrocardiogram findings and physical examination. Then this image gives you the overall study design. As you can see here, all of the 24 weeks are here, but before that, the participants had a screening visit, and after the 24 weeks, on the 26th week, they had end of study visit. And you can see that the drug and the placebo, it was given subcutaneously, and then the three groups. The normal saline group, the group number 2, which was given investigational drug in 0.56 mg, and then the group 3, it had the investigational drug, but in the dose was double as compared to group 2. And then all of the participants, they were receiving the donepezil. It's the brand name. The injection was given during and before the clinical trial. And here you can see they performed evaluation on the baseline, and then midterm, and then final. And you can also see that the number of participants, when the study started in the placebo, in the control group, they had 31 participants, but by the end of the study, they had left only 26. And same thing in the group 2, they had 33, but by the end, they had 22. And in the group 3, they had 32, but by the end, they had 25 participants left. And then the ethics approval, the declaration that they have given in their paper, according to that, all the all the institutions that were involved during this clinical trial, they had their independent approval. They gave their independent approval. So this is a multi-center clinical trial, and it took place in South Korea, and all of the centers that were in this clinical trial, they all gave their independent approval, and all of the participants, they also provided written informed consent. Then moving on to the results, they recruited 96 participants. They screened 109, but they excluded 13. We will see why they excluded 13, but before, just have a look at this. By the end of the study, they had 26 participants in the placebo group or the control group, as we saw earlier in that image, and 22 in the group 2 and 25 in the group 3. Here we can see in this image, this is overview of all the recruitment and all of the participant numbers. They screened 109, but they excluded 13 because they didn't meet the criteria. And then they randomized 96. But after the randomization, one was excluded, and so they were left with 95. So they divided the 95, and it's 31 in group 1, 32 in group 2, and 32 same in the group 2. And this is full analysis set. It's a practice in clinical trials that they evaluate the participants based on the intention to treat criteria, not what they actually got. That is different approach. That is per protocol set. This is also given here. So in the intention to treat, they had 81 participants, and in the group group that actually got the treatment that was planned for them, they had a total of 73 participants. And then is the primary outcome. As we discussed, the primary outcome was the SIB score, severe impairment battery score at week 24. And according to that, the difference between the group 1, that is the normal saline, and the group 3, that is the investigational drug, but its dose was 1.1 2 milligram. The difference was 6.6 in the full analysis set. That is the evaluation that is performed taking into consideration only the participants that were intended to receive a particular treatment, not what they actually got. It is a standard practice in clinical trials. Why they do is they eliminate all the biases, and it's a necessary. And then in the per protocol set, this is the set of evaluation during which they evaluate only those participants that they actually got the treatment that was assigned to them. So in both of these, we can see here it is 6.6 and here it is 7.1. So the difference is statistically significant. And in these group, the difference between group 1 and group 2, again, it is the group, it has the investigational drug, but its dose is half as compared to group 3. The difference was in favor of group 2, but it wasn't statistically significant. Here we can see the same thing. We can see the same thing. The placebo, you can see the placebo is not changing. It's continuing its decline. It's not interrupted at all in both of these groups. In the full analysis set and the per protocol set, the placebo is going down with the same rate. But you can see that the group that got the actual drug in 1.12 milligram dose, it actually experienced less decline in the SIB score. So we can see all of the groups, they have the same SIB score when they were evaluated before the start of the trial. That is the baseline evaluation. All of them, they have the same result in both of these analyses. But the group number 3, it clearly shows a trend that it experienced a less decline in the SIB. And then the group 2, it also experienced less decline, but it is more than the group number 3. So what it tells us that the response is dose dependent. Like in this one, the dose is less, so the decline has reduced by a less amount, but in the group 3 and the orange dot, it has more dose, and therefore the response is more in this one. So it shows a dose dependent response both in the full analysis set and the per protocol set. Then is the secondary outcome. If you remember, in the secondary outcome, they had bunch of other tests. In those all, only two performed well, and that was still was not statistically significant, and therefore they didn't took into consideration that its value even is not provided here because it is not statistically significant. But still, it was in favor of the investigational drug group. Here you can see the graph here. These both graphs are for the secondary outcome. We can see that the trend is in the same direction, but it is not like very significant. You can see that the placebo group, it continues its decline in both of these analyses, but the groups that were given the actual drug, they experienced less decline, but it is not like very significant. And then the safety, they did not experience any of the treatment emergent adverse effects. Two adverse effects that happened, they were both in the placebo group. One was hospitalized because of a fracture in the one arm after a fall, and one was diagnosed with the stomach cancer. But both of them, they were in the placebo group. And then moving on to the discussion, as previously stated, neuroinflammation, it plays a part in the pathophysiology of Alzheimer's disease. So there should be a way to counter the neuroinflammation as well. GV1001, it's an antioxidant drug. It has anti-inflammatory, anti-aging, and mitochondria stabilizing effects. It was actually designed for the pancreatic cancer, and there it did not produce any significant effects, and therefore it's not being used there, and it's not being pursued there. But in the animal studies, it did produce some anti-inflammatory effects in the neurons, and therefore it's undergoing clinical trial. And this is phase 2 clinical trial, and here we also saw that it is producing some effects that are beneficial to the Alzheimer's disease patients. Just keep in mind that it is a combination with donepezil. And then in terms of safety, it was as safe as the normal saline. We did not encounter any major adverse effects in the groups that were receiving the actual drug. Then limitations can be pointed out. One, I pointed out earlier that it is using DSM version 4 and not the DSM version 5, that is the latest. And in addition to that, it can be mentioned that all of the participants, they were from single ethnic group, and since it's a phase 2 clinical trial, so the sample size was less as well. A phase 3, I think maybe that will be beneficial, because having more sample sizes can tell you how does this drug do with other comorbidities, because we're talking about an age group that is already very older, and they definitely would have some chronic diseases, and it will be interesting to know how this drug does with the other chronic diseases. And then the duration was short. Another thing and a very important point is they didn't perform the pharmacokinetic analysis of the participants, evaluation of the participants. They did conclude that the effect is dose dependent, but that they did by giving 2 different doses. In the pharmacokinetic, what advantage it gives you, like you can measure the blood concentration of that drug, and once you have that, you can relate that to the biomarkers. That is the point number 4 in the limitation. You can relate that to the biomarkers, like when the concentration of drug is increasing in the blood, how is it affecting the biomarkers of Alzheimer's disease. I think that would have given a more micro perspective on the even on the mechanism of this drug, like how it relates to microfluctuations in the blood, how the blood concentration relates to the biomarkers of Alzheimer's disease. So that I think can be done in the phase 3 clinical trial. And then in the conclusion, as we saw in the results, it does have some beneficial effects on the cognition of individuals that are already taking donepezil, and that effects were proven in the SIB score. Then, as I mentioned earlier, it deserves an investigation on phase 3 clinical trial that will have more sample size. And then that phase 3 clinical trial, it can have it can take into consideration the effect of concentration of the drug in blood on the biomarkers of Alzheimer's disease. The impact of this drug, it is providing another strategy to just target the multifaceted pathophysiology of Alzheimer's disease. Because we need to attack Alzheimer's disease from different angles. What we are facing right now is that all of the treatments that are based on myeloid cascade hypothesis, they're not doing well in the clinical results. So maybe we can attack Alzheimer's disease from different angles and see how they work together. In this one, they only added this investigational drug GV1001 in addition to donepezil. But in future, they can what they can do is they can add it in addition to the aducanumab that is recently approved. It was approved actually after the results were published and after the clinical trial was performed. So the phase 3 clinical trial, it can actually have the drug in addition to aducanumab as well. So then we'll have 3 different angles from there. We will be attacking the pathophysiology of Alzheimer's disease. So that I think can be helpful in improving the quality of life of the Alzheimer's disease patient, even if it doesn't cure Alzheimer's disease, even if it doesn't improve the lifespan. If it improves the health span, and if it improves the quality of life, I think that can be a huge advantage and a huge benefit for Alzheimer's disease patients. Thank you so much.
Thank you so much, Numair, for that talk. I will now open the floor to the audience for any questions, comments, or criticisms they may have. So Nupur has 2 questions. She asks, what does severe impairment battery mean?
Severe impairment battery, it's a clinical criteria to just measure how the patient is doing. It's not taking into consideration the biomarkers and all. It's only considering the overall general perspective in the clinical terms, like how is the patient doing on the cognition. It actually measures their cognition and relates to whether they are good on the cognition or bad on cognition. And in this one, the clinical trial, it showed that the investigational drug, it did perform well in SIB terms.
Her second question is that is there any side effects of the drug?
The side effects, they didn't notice any prominent side effects. There are if you give a drug, most of the times it can have some off-target effects, and that can be included in the side effects. But they didn't notice any major side effects that would have stopped this drug from going into phase 3 clinical trial.
Shaheen had a question. I hope that answered your question, Nupur. Shaheen also had a question. She asked, what sort of side effects do people face while taking AD symptom managing drugs like donepezil and galantamine?
So the currently drugs, they have number one side effect on the GIT. Patients suffer from abnormal GIT functioning. It can be constipation or nausea. But the major problem with this one is that it is not controlling the pathophysiology of Alzheimer's at all. Maybe its side effect, if they are not severe, then its actual effect is not effective either, because it's only managing this symptom, and that is only one symptom. It is related to the short-term memory only. What we need is some way to either stop or reverse the neurodegeneration that is happening in Alzheimer's disease, but these drugs are not doing that. To come back to your question, it does have side effects, and side effects are on the GI.
I hope that answers Shaheen's question. Vijay asks, is the suggested dose for the drug for the limited period or lifelong administration will be required?
Whenever these amyloid beta, the plaques are there, the tangles are there, they will continue to cause the inflammation. So as long as the inflammation is there, the drug should be given. If it doesn't cure Alzheimer's disease then I think the drug should be continued throughout the life. So either way, if we are able to control Alzheimer's by giving lifelong therapy, I think it's still a plus, because these drugs, it is not removing those plaques. As long as they are present, they will continue to cause inflammation, and as long as there is neuroinflammation, this drug will be given.
I hope that answers your question, Vijay. Dr. Bharati also has a question. She asks, is the drug used only for Alzheimer's disease or any other diseases as well?
There are other diseases, neurodegenerative diseases. They have neuroinflammation in them. I think it can be used for that, but currently there's no data to suggest any such role. It was originally designed for pancreatic cancer, but it didn't produce any encouraging result there. But yes, it has potential that in the general neuroinflammation is present in many other diseases. So it can be used in future for other such diseases. But for now, all of the focus is on Alzheimer's disease.
I hope that answers your question, Bharati. I see no other questions in the chat box and in the question answer session, in the question answer panel as well. So I would request Numair to go to the last slide. So thank you all for your questions and your presence in today's webinar. I would like to thank Numair again for today's webinar. And so in closing this, I would also like to inform the audience of the next CellTalk webinar that will be held on the 1st of November 2022. And Ms. Aditi Ratnam will be presenting the paper YouTube as a source of information on neurosurgery. Thank you so much, everyone, for your presence today again. And we hope to see you this time next week. Wishing you a great week ahead. Good evening.